Hello, my name is Wade Green, and this is my switch presentation, Moving Up Market in Healthcare, Athletic Trainers as Critical Primary Care Providers. The Affordable Care Act has afforded millions of Americans the opportunity for medical insurance and increased access to healthcare. However, we're seeing a downward trend in the number of primary care providers that are directly accessible to this population. In addition, the current HMO plans that are being provided by the Affordable Care Act and being mandated by the Affordable Care Act are pushing more people into primary care without enough providers to provide care for that population. This creates a very interesting situation for healthcare providers in general, as well as primary care physicians. In a situation where primary care is being demanded more and more, yet the primary care physician has fewer resources and time to be able to address those concerns, there are two main solutions that have been proposed in the literature for this problem. Those are skill mix and role shift. Skill mix is essentially embracing of the skill sets and scopes of practice of many different providers inside of an interprofessional network and or practice, such as the athletic trainer, the RN, the nurse practitioner, or the PA. Utilization of the athletic trainer for musculoskeletal concerns could be a primary advantage for the primary care physician. Additionally, things like concussion education would be well executed by the athletic trainer in the primary care setting. But how do we direct the rider? How can we potentially describe such a change to the athletic training profession? We can do so by telling them that many of these steps have already been laid out for them. The Practice Analysis 7th edition that has been published by the Board of Certification details the 5 domains of practice of the athletic trainer in a very succinct and logical format. Many of those domains fit squarely within primary care, and additionally, the primary care literature points to areas where either quality improvement is necessary and or the prevalence of things like musculoskeletal problems could be adequately served by the athletic trainer, as 1 in 7 consultations to primary care providers are for musculoskeletal concerns. The critical moves for this type of a transition into primary care involve utilization of EBP with outcome measures, the critical step of documentation properly, as well as documentation of outcomes, and then taking those pieces and expanding those into populations not traditionally served by athletic trainers, such as the aging population, those in military settings and law enforcement, as we're doing already. But what about the destination? The destination should be described by diverse patients, increased number of services provided by the athletic trainer, high quality of care, and ultimately greater revenue and throughput. How do we shrink the change? P4 medicine is a framework that has been discussed by authors such as Jimmy Anati for describing the athletic trainer's role within primary care. P4 stands for care provided by the athletic trainer that is predictive, preventative, personalized, and participatory. This parallels very well with the domains of athletic training practice, as many athletic trainers in the traditional setting find themselves utilizing those types of tools and approaches daily. But what about the elephant? The elephant might object to this type of a change. This is not what they're used to. But how can we possibly get the elephant to buy in? I think a very important key is work-life balance. It could very well be that structured hours and scheduling afforded by primary care practices, fewer weekend and Friday afternoon hours, and shared responsibilities among staff members could really help drive the change and motivate the elephant within this change. But how do we get there? Athletic trainers might argue that they're already engaged in primary care, and there are residencies that are tailored to the athletic trainer within primary care. But are those residencies accessible to the profession as a whole? And how long will it take until there are enough residency programs to provide this type of experience? Specialty certifications are not well enough developed for this type of a change. But what about the DAT programs? Can DAT programs provide the foundation for primary care? These are critical questions that will need to be answered in the coming years as this problem is continued to be developed. What about path shaping? How do we redefine primary care? Can the athletic trainer drive preventative efforts in primary care? Should the primary care shift to a walk-in clinic, as is more common today? What about outreach? Can the athletic trainer capitalize on things like wearable technology with patients to measure things like heart rate and glucose in patients that are pre-diabetic or pre-hypertensive? What things do we let go of in our practice? Maybe we need to let go of things like performance enhancement, strength and conditioning, and then non-medically related compliance issues like drug testing and others. Letting go of these things will allow us to move up market in healthcare, not only within primary care, but within healthcare in general.